I hope this is the last person. Not the last. We are 70, 74, 75 people. 77. Oh my God. So please switch on the microphone. Okay. It seems to me we need time to prepare for the meeting. More people. By the way, you can join us not from not one person, one student from one computer, but you can cooperate with other students, and thus you can be present from one computer, 3 or 2 students. By the way, while I'm accepting your invitations, I'm sorry, but it's technical problems we have. I want to remind you that you have to write MCQ in our portal. It is in the department Anatomic Pathology named after Strukov, and everything is in English. And I think it's already in Farsi, if I'm not mistaken. There are several languages that are active. And there you can find MCQ for the classes. And we ask you, our department asks you to write all MCQ. So if we discuss unit number 4, it means that you have to write MCQ for the unit 2, 3, and 4. And we collect the marks from site, or we will collect the marks directly from you. Okay, so don't forget to switch off microphone.
Excuse me, Professor, I have a question.
Yes.
About the MCQs. Can you send us the link for this website, or where can I find MCQ again?
Okay. Yes, I will do it. I will do it in WhatsApp, or I will send it here if we have time left. Okay.
Okay. Thank you very much.
No problem. So all questions, please. We're here for you.
And
so,
another question.
Yes, please.
Yes. Could you please record this conference?
Good idea. Yes. Why not? I'm not very good in it, but I'll try. And another bad thing that we have only 40 minutes for Zoom, because for free version, maybe I will buy and it would be bigger. Okay. To record the conference, I have. Please switch off microphones.
Okay. Okay, I still accept invitations. Do you hear me?
Yes.
Yes. Okay. 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 I think I have disconnections with my earphones. Okay, no problem. Oh, we're almost 100 students here. That's perfect. Okay. So, also I need to find how to record the conference. Okay, thank you. Thank you very much. Okay, so we discussed with you we have to discuss with you injury of connective tissue and the types of the injury is different variants of swelling, mucoid, fibrinoid, swelling, hyalinosis. These are the stages of injury of connective tissue. And amyloidosis, it's another variant. We'll discuss later about this. So usually mucoid change is the injury resulting from either antibody-dependent accumulation in the connective tissue or due to hypoxia or injury due to high blood pressure that we see in blood vessels in arterial hypertension. In mucoid change, we see formation of swelling in the connective tissue. And this is the slide that we have to investigate with you. It's toluidine blue staining. This slide shows us the phenomenon of metachromasia. In the area of mucoid change, we see transformation blue color to violet color. But what is mucoid change? This is a result. This is a result of accumulation of glucosamine glycans in connective tissue. In these glucosamine glycans, they usually accumulate as a result of antibody-dependent injury. So what is going on in connective tissue? For example,
20, only 6 people are there. So 100 people only
I hear somebody.
Some 80. How much will be, how many groups will be? 66 to 80 means how many classes total? Or group 10 or 11.
I hear somebody.
80 means how much? 18 7 to 10 classes.
Twinkle, please turn off your microphone. We can hear you.
Yes, thank you. Thank you.
You're welcome.
Okay, so we are back to this very complicated thing, mucoid swelling characteristics. In the case of antibody-dependent injury, we see accumulation, for example, immune complexes or antibodies in connective tissue. This results in activation of macrophages. Macrophages, of course, they're activated by immune complexes. Macrophages activate fibroblasts. Fibroblasts produce glucosamine glycans. These are very hydrophilic substances. And glucosamine glycans connect water. That's why we see enlargement of connective tissue and we see swelling of connective tissue. But it is called mucoid because the inside is glucosamine glycan that binds water. Okay, so in this area in connective tissue that has glucosamine glycans, this is the area that stains in violet by toluidine blue, and we call it phenomenon of metachromasia. We have with you electron micrograph, mucoid changes in the connective tissue. Look here, these are the collagen fibers, and they are not injured, but between we see a lot of spaces. These spaces are results of mucoid swelling. They contain glucosamine glycans in water, and they move the collagen fibers so they move and they make the distance between the fibers bigger. That's why we call it swelling. Very important thing that this process is reversible. It means that if the pathological stimuli would disappear, it would disappear. The process would disappear. Mucoid change gone and nothing stays after. Collagen fibers are normal, they're not disturbed, and they're not injured. It's very important. That's why this process is reversible. And now we move to your slide that you have to put down in your workbooks. It is the mucoid change of the valvular endocardium in rheumatic heart disease. And I'll do like this. Okay. Okay, so here you see the picture. You've already seen it in a previous slide, but in another area. This is the valvular endocardium. And in the valvular endocardium, there is swelling, mucoid swelling. We see phenomenon of metachromasia. We see that it's not blue, but it's violet. This is due to mucoid swelling. This is due to accumulation of glucosamine glycans. What is the pathogenesis of it? Pathogenesis of rheumatic heart disease, of rheumatism, is based on antibody-dependent injury. But these antibodies are not directed against endocardium. But for the first time, these antibodies usually are directed against streptococcus, beta hemolytic streptococcus type A. And these antigens that streptococcal antigens that trigger formation of antibodies, they are very similar to antigens of the heart, of endocardium, for example. That's why antibodies that are formed against streptococcus, they cross-react with antigens of endocardium, of the antibodies of human. Due to this cross-reaction, we see formation of antibody-dependent injury of endocardium. And the first step of this injury would be mucoid change of the valvular endocardium. And this scheme shows us the normal endocardium, and it would be number 2, and you have to stain it in blue color, and the focus of mucoid change. It localizes in valvular endocardium, and it would be stained in violet color, like here. So we move, but my computer doesn't want to move.
Can you wait a little bit, like 1 minute?
Excuse me?
Ma'am, can you please pardon for once?
1 minute just to write this in the...
Okay, yes, please. But don't forget, we have only 40 minutes.
Okay.
By
can
the
you please
way,
pardon it once? Which one is 1 and which one is 2? Can you please pardon?
yes, please. Number 1 is here. Oops, sorry. Okay, I will. Number 1 is here. Do you see me? Yes. And number 2 is here. Unaffected endocardium.
Excuse me, ma'am, can't see it.
You can't see the pointer?
Teacher.
Yeah, now I can see it. Can you please repeat it once more, please, ma'am, please?
Yes. I will do in another way. I will make. So this is number 1, and this is number 2. Do you see the changes?
Yes, ma'am.
Okay.
Yes, ma'am. Thank you so much, ma'am.
Welcome. By the way, on your news website, we have MCQ, and we have lectures, and we have seminars. I mean, the presentations that we're discussing. They're on the website, not only on Google Disk. And I ask you to be active on the EOP, try to enter there and to take information from this place, from the new portal, Student Sechenov. I will send later the address.
Teacher, I have
Yes.
a question. Can I leave the meeting because some students want to come to the meeting?
Yes. What should I do?
Because the participations are over than 100 and some of them wants to come to the meeting, but it's complete now.
Okay.
So can I leave the meeting to make a free place for them?
Yes, of course.
Thank you.
Okay. So we proceed. After mucoid changes, when it precedes, we see formation of more serious changes. They are called fibrinoid change. What is going on in this case? In this case, we see swelling of not only the we see not only swelling of the connective tissue, but also we see injury of collagen fibers. It's a very important thing. Why this happening? The vessel permeability increases in mucoid change, and at first time, small molecules of proteins go inside connective tissue, but later larger molecules of protein go inside the connective tissue, and fibrinogen. The fibrinogen converts to fibrin and injures the collagen fibers. This results in irreversible injury of connective tissue. This would be called later fibrinoid. These deposits of extracellular matrix and fibrin.
So, ma'am, for the fibrinoid change, it takes place in the collagen fibers, correct?
In the connective tissue, and it is result of destruction of collagen fibers and proteins.
Okay, thank you.
So what you've already heard from me, we discussed with you one variant of injury, mucoid change, that can precede to fibrinoid change. And this mucoid injury is usually triggered by antibodies, immune complexes. So it's immune injury. And the thing is that mucoid change is reversible because collagen fibers are not affected. And fibrinoid changes are irreversible because collagen fibers are destroyed or injured. After the fibrinoid change, the process goes to sclerosis, hyalinosis. Okay. We have electron micrograph, if I'm not mistaken, in your workbooks. This is the fibrinoid change. And these are the collagen fibers, and you see that they are injured, they change their view, they change their appearance, and we see deposits of protein in between the collagen fibers. This is what we see in electron microscopy. Hyalinosis, so it's the last stage of these changes in connective tissue. It's not only the foci of sclerosis, but it also the foci of degeneration of collagen fibers and extracellular matrix. The most common extracellular hyalinosis is found in rheumatic diseases and hypertension. Hyalinosis is usually divided, as you see on the slide, into vascular hyalinosis and hyalinosis of connective tissue itself. Example of hyalinosis of connective tissue is hyalinosis of the valves in rheumatic heart disease, in rheumatic fever. We can classify hyaline changes into two types: intracellular hyaline deposits, accumulation of protein, hyaline droplets dystrophy, Russell Mallory borders, but inside the cell, or extracellular hyalinosis in the walls of blood vessels and intracellular substances, deposition of hyaline. That's what we see in rheumatic heart disease and what we see in hypertension. Because in hypertension, there would be injury of the vessels due to high blood pressure, arteries. And this would cause increased permeability of the vessel, accumulation of protein inside the vessel wall, and finally, formation of hyalinosis of the vessel wall. Okay, so we move. What are the processes before hyalinosis? It can be, like I discussed with you, plasma impregnation. Due to high blood pressure, the vessel wall would be impregnated by plasma and by protein. Fibrinoid swelling, fibrinoid necrosis, for example, in the case of rheumatic heart disease. Inflammation can also be the cause of hyalinosis, and necrosis and sclerosis also can be before hyalinosis. And we discussed with you the gross. The gross hyalinosis of the valves in rheumatic heart disease. We see the valves. This is the mitral valve. We see that the chordae tendineae are shortened and are thickened, and the leaflets, firm consistency, they are thickened, they are white, they are now more translucent, and this is a result of hyalinosis and sclerosis. Due to this specific appearance of the mitral valve that can be opened normally and closed normally, it would be not only a stenosis but insufficiency of the valve. These changes are called, the figurative name for these changes would be fish mouth appearance. Please pay attention that we have enlargement of the myocardial wall. It is called hypertrophy, and this hypertrophy is a result of these changes in the valve. So, what you have to put down? You have to put down that the leaflets of the valve become thickened, deformated. The chordae tendineae become thickened, shortened, fused. The figurative name for this would be fish mouth. And very important thing that the size of the heart would be enlarged. See, the thickness of the left ventricular wall increases due to hypertrophy. Okay. Microscopical appearance of hyalinosis. A very good example of this would be hyalinosis of the spleen artery. This is what we see in people with hypertension, for example. Person with increased blood pressure, we see hyalinosis of arteries in many organs. We'll discuss this disease in next semester, and you will find out what would be the consequences of this. Anyway, we see that the lumen of the central artery is narrowed and the wall of the artery is thickened. And this wall contains homogeneous masses of pink color. It looks like hyaline cartilage. That's why we call it hyalinosis. It's not the cartilage, but it looks like hyaline cartilage. That's why it has such a specific name. So finally, what we see that the artery wall is thickened. It is the wall contains homogeneous pink masses resemble hyaline cartilage, and it is called hyalinosis. And the lumen of the artery is narrowed. What can be the consequence of such hyalinosis with the narrowing of the lumen? Of course, hypoxia. And hypoxia results in dystrophic changes in organs and sclerosis in organs. And if we investigate kidneys of a person with increased blood pressure, with essential hypertension or arterial hypertension, we would see that due to hyalinosis of the arterioles of the kidney, there would be decrease of the kidney size. Pay attention that both kidneys are decreased in size. The surface is not smooth, it's irregular, it is nodular. And on the card surface, we would see narrowing of the cortex and narrowing of medulla. Such prominent hyalinosis of the kidney arteries, arterioles, can even result in kidney failure and people can die even from chronic kidney failure. On the microscopical examination, we can see what is going on here. We see that due to hyalinosis of the arteries, this is number one. Due to hyalinosis of the arteries, there would be hyalinosis and sclerosis of the glomerula. Look here, this is the artery. Oops, sorry. This is the artery. And this is glomerula. Due to hyalinosis of the artery, there would be hyalinosis of the glomerula, and of course, dystrophic changes and atrophic changes of the renal tubules, and sclerosis of the kidney interstitium. And survived glomerula have to work harder. That's why they undergo hypertrophy. If we move to our scheme, we see that number one is the artery, sclerosis, hyalinosis of the artery. Number two, there would be total sclerosis of the glomerula. Number three would be foci of the tubular atrophy. Number four would be interstitial fibrosis, like here, like here. And number five is this, hypertrophy of unaffected glomerulus. I hope you had time to put it down, and we move. What are the diseases that have connective tissue injury in its base? And it is antibody dependent. It is rheumatism, systemic lupus erythematosus, polyarthritis, sclerodermia, rheumatoid arthritis, and the others. Amyloidosis, it's a kind of an injury, but amyloid is a very specific thing. It's a pathologic protein, but it is formed from normal precursors. And amyloid is never deposited inside the cell. It is deposited in the extracellular matrix in the connective tissue. You have the lecture, you can understand what is congruent staining from there. Also, you have Robin's pathology, but I tell you, to verify amyloid in tissue, we have to stain the tissue for congruent staining, and you have to look it in polarized light. If we see apple green light, we see that it is amyloid. So this is due to special structure of amyloid protein. There are different variants of amyloid. It can be hereditary, it can be secondary. It can consist of different chemical substances. And the most typical thing, I'm sorry, please. Уйди, пожалуйста, я занимаюсь сигаретами. Да, очень хорошо. My child is very active also. Okay. We will discuss, you can understand you can find lecture material and look what different variants of amyloid are. But I'll tell you about AL amyloidosis. That is usually primary amyloidosis derived from plasma cells, and it is usually in diseases like myeloma, multiple myeloma. AA amyloidosis, it's the variant of amyloidosis that is a result of chronic inflammatory diseases. This amyloid is synthesized from SAA protein, plasma protein that is accumulated. So it's inflammatory protein, and it is accumulated in inflammation. And in a case of chronic inflammation, hepatocyte do not have time and ability to metabolize it. And from SAA protein, we see formation of AA protein. And this is a variant of secondary amyloidosis. It can be local and systemic, and you can find this classification, and we don't have time to discuss it because it's also it can be as a result of hemodialysis associated amyloidosis, and etc. So I want to show you what would be in the organs if they accumulate amyloidosis. The organs increase in size. So, but which organs usually affected? Many organs. Of course, parenchymal organs and spleen and kidneys. In some cases, it can be heart. Vessels are always affected and accumulate amyloidosis. And for the spleen, we see two stages of amyloidosis. We see the first stage is called sago spleen and Lardascio spleen, that is the second stage. And we have to discuss with you these grosses, deposits of amyloidosis. If it's sago spleen, we see like sago seeds on the card surface of the spleen. Of course, it's enlarged in size, it's firm consistency, but we still see the areas of pulpa. We call it sago spleen. It's like the first stage, the earliest stage of amyloidosis. And if we did not see the pulpa at all, we see that on the card surface, the enlarged firm spleen has waxy appearance. It is already the Lardascio stage or Lardascio spleen. Okay. And we have with you two slides. Sagospleen. Please pay attention that amyloid, that is red color, it is, by the way, Congo red staining. Amyloid is deposited in the follicles. This is lymphoid follicles. And the inside, we see deposition of amyloid. Plus, of course, to this, we see the deposition of amyloid in the spleen arteries here. And red pulper, this is the red pulper, is free of amyloid. So back to our scheme. Red deposits in amyloid in splenic follicles. It's number 1. Red deposits in splenic vessels. It's number 2. Atrophy of the follicle of lymphoid tissue, of course. And here, this is the red pulp that is free of amyloid. As I think you understand, if the pathologic process proceeds, there would be dissemination of amyloid to red pulp. So as a result of this, we see such a picture. We see total infiltration of spleen by amyloid, atrophy of the follicles. We even can't see where is the follicle, where is the red pulp. So we see amyloid in the vessel walls, number 1, in the follicles. Oh, it's number 3, I'm sorry. It's number 3 here. And number 2, in the red pulp. Amyloidosis in the red pulp. So we discussed the amyloidosis. We discussed that it is disease, but we didn't discuss with you what is going on with organs in this case. The point is that amyloid is a very firm protein, and accumulation of amyloid in organs results in atrophy of parenchyma and sclerosis in stroma. So what would be with organ function? It would be decreased. So if there would be amyloidosis of the kidney, what would be with the kidney? Kidney failure, finally. And if we discuss amyloidosis of the kidney, I tell you that there would be several stages. Clinically, these stages would be characterized as preclinical stage or latent stage, when we see just the accumulation of amyloid only in basal membranes of the capillaries. And then there would be the proteinuria stage, and we discussed with you with the nephrotic syndrome. It can be nephrotic syndrome as well. Then there would be the stage of nephrotic syndrome, or when there is edema, decrease of the blood protein, and increase of the protein in the urine, and dyslipidemia. And the last stage is called azotemia, or kidney failure, when we see amyloidosis everywhere in the kidney parenchyma, and in kidney stroma, I'm sorry, in all basal membranes, in glomerular matrix, and in between cells, in extracellular matrix of the kidney. And this is characterized clinically by kidney or renal failure. I see that we have an electron micrograph amyloid within glomerular basal membrane. It's the beginning of amyloidosis. And let me see if we have it. Oops. Okay. No, we don't have it, but I have to tell some words about it. So in this case, we would see only thickening of the basal membrane of the glomerula. Okay. And luckily, we have more time with you. It's already 45 minutes. And we have to discuss cases as well. But before cases, we have to discuss amyloidosis of the kidney. It's a big white kidney. Big white kidney. The kidney is big, firm consistency, and the cut surface, it has a waxy appearance. Of course, it's already azootemic stage of amyloidosis of the kidney. It's the last stage. Okay, so now, well, we have with you cases. Maybe we can discuss cases now. What do you think?
Excuse
Maybe
me, what is the figurative name?
Big white kidney. So I think we can discuss cases now. What do you think?
I think it's better we discuss the cases along with the score.
Okay. So we have the case. You can see it. Man, not young, not very old. Renal dysfunction, impaired renal function. Oops, sorry. And he has cavity fibrocaseous tuberculosis. And he dies due to renal failure. The thing is that this variant of tuberculosis, so anyway, tuberculosis is a disease, inflammatory disease. And in this case, there would be increase of SAE protein. So, due to this, what kind of renal pathology can this patient develop? What do you think?
Secondary amyloidosis.
Exactly. Exactly. So, what type of abnormal tissue accumulation can be found in the kidney?
Amyloid accumulation.
Accumulation can be found in the kidney.
Exactly, exactly. Can we describe the histologic changes in the kidney and explain the mechanism of their development?
Yeah. There's going to be called inflammation, which is going to lead to macrophage activation, which is going to lead to interleukin 1 and 6 activation. Then the liver is going to interact with the amyloids, which is going to activate SA protein and limited proteolysis, and then amyloid proteins are going to be there.
Mm-hmm. Exactly. Very good. So, and if we describe the histologic changes in the kidney, where would we see, in this case, in renal failure, where would we see amyloidosis? And what staining should we use for this?
Congo red.
Congo red staining, absolutely. With that polarized light we need.
Yeah, then we're gonna see the green color.
Yes, apple green staining, perfect.
Apple green staining, yes.
And where do we see accumulation of amyloid? In which areas?
In the glomerulus.
Glomerular filter.
Glomerular filter, glomerular basal membrane.
Yes.
Where else?
Where else? Or maybe in the arteries and the arterioles?
Of course, perfect. In the artery walls. Do we have renal, proximal and distal renal tubules? They have basal membranes. There would be also amyloidosis.
In the intestinal peritubular tissue.
Excuse me?
In the intestinal peritubular tissue.
Yes. Okay, perfect. We have the question number 4, but we've already answered to this. What stain? Of course, Congo red. And we have the question, what changes can be seen in the glomerular filter under electron microscopy?
Accumulation of fibrils of amyloid in the glomerulus.
Yes. Very good. So, and of course, I have the answers for you here. Where are my answers? Moment.
I can't see your screen actually.
Excuse me? You don't see my screen? Guys, do you see my screen?
Yes, I can see it.
Yes,
I can see it.
Okay, perfect. Thank you. It's very hard that we are not in a class. But it's better. I'm sorry, I can't understand.
And Mom, I see your screen and it continuously connecting and
I'm sorry, I don't understand. Some connection is not very good. That's why I can't hear you perfectly. Okay. So we move. Case number 8. Very similar case. Knowing the discussed material, what do you think is going on with the patient? What is the syndrome?
Nephrotic syndrome.
Nephrotic syndrome, perfect, correct. What is the cause?
Amyloidosis, secondary.
Exactly, secondary amyloidosis, yes.
Like inflammation, chronic inflammation.
Exactly, yes. Because he has osteomyelitis. It's suppurative chronic inflammation in the bones. Yes. Okay, what would be with the kidney on gross inspection?
It would be normal in size and color.
I think it's going to be enlarged and pale in color.
Or yeah, it may be enlarged and have waxy appearance.
Yes.
And guys, can we just have the teacher talk, because your answers are confusing me, please.
The thing is, she asked us to tell the answers.
I know, but 2 people are talking. Can we then have one person?
Okay, ladies, you're almost both correct. So we see that there will be amyloidosis of the kidney, and we will describe with you the growth from our workbook. Yes? The growth that we discussed with you before. The kidney is enlarged in size. It's firm consistency, and on the cut surface, it has waxy appearance. Yes?
Yes,
And
that's
now
what
we have a very similar question, number 4, similar to previous case. Please, who can answer?
Is it the last question, Professor?
No, it's the pre-last question. It is number 4.
Oh, okay. I
Describe
think
histological changes and mechanism.
the mechanism is going to be the same as the last one. Chronic inflammation is going to lead to macrophage activation, which is going to the production of interleukin 1 and 6. The hepatocytes are going to interact with the amyloids, going to produce the SA proteins. There's going to be limited proteolysis, and then there's going to be SA protein. And we will see amyloid deposits in the walls of the glomerular capillaries, maybe in the intestinal tissue of the kidney, under the endothelial cells, and etc.
Okay, so look here. One interesting hint for you. We have with you here the patient with nephrotic syndrome. Nephrotic. It means that he is not on the last stage of amyloidosis of the kidney, but on pre-last stage, the stage of nephrotic syndrome. It means that he has amyloidosis. Sure, he has amyloidosis in the kidney arteries, in the glomerular filter, in the basal membranes of the tubules, but he still doesn't have amyloid in the interstitium. He will have amyloid in the interstitium later, when he will develop kidney failure. Okay?
Yes, got it. Thank you.
Thank you. And the last question.
In which other organs may this pathological process develop? Amyloid deposits may be found in kidney, liver, lymph nodes, adrenals, thyroid gland, and other tissues.
Which other tissues? For example, you're a clinician. You suspect amyloidosis in the patient. What would you do? You can't make a biopsy of the kidney if you suspect amyloidosis. Where would you take biopsy from? What do you think?
Blood.
Amyloid. Excuse me?
Blood.
Gut.
Distinct from the blood.
From the blood. From the blood. By the way, maybe you can find antibodies. You can make antibody tests. But usually we take tissues for this because amyloid is a protein that deposited in the tissues.
Maybe abdomen fat? No?
Yes, but it's not very positive. It's not always very positive. We have patients from the clinic number 3 here, and we usually take biopsies of the cutaneous tissue, subcutaneous fat tissue, but it's not always positive. But for sure, it would be positive in the gum, in the mouth, and in the rectum, because all the gastrointestinal tract would deposit the amyloid protein inside. So that's why we recommend, it's recommended to take biopsy from the gum or from the rectum. By the way, in some cases, amyloidosis injures nerve endings, and the patient develops neuropathies. And for this case, of course, the biopsy of the skin is performed and analyzed on amyloidosis. Also, to analyze the tissues for amyloidosis, we can use not only congruent staining, but specific proteins, antibodies. We perform immunohistochemical examination using specific antibodies. That's why we can check the variant of amyloid that is deposited in these tissues. Okay. So, and we have, I have the answers, by the way, for you. You can see them. Okay. You have this unit on the web. That's why I proceed, because I'm afraid we would be switched off by Zoom. And the last case. Do you remember I told you that injury of connective tissue not only be by antibodies, by immune complexes, but also plasmorrhagia, high blood pressure with injury of blood vessels. And in this case, the patients had atherosclerosis and high blood pressure, and he dies from chronic heart failure. So, the first question, please.
Benign nephrosclerosis.
Oh, okay.
You go ahead.
Guys, I understand it's very hard. We are many people.
Do you want me to go ahead?
Yes, please.
Sheena, you can go on.
Benign nephrosclerosis.
Yes, yes. And describe, please, the kidney.
The kidney would be enlarged.
No. Stop laughing.
No,
The
the kidney
kidney
would be reduced in size.
Reduced in size, exactly.
Yeah, and firm. And
reduced in size, firm consistency.
And
so mom, we can say dystrophy, right?
I didn't understand. Sorry. I
we,
want to hear
so
the
we can say dystrophy, right, ma'am? Dystrophy, yes.
He's saying, can we say that?
We don't see dystrophy on the gross inspection because dystrophic changes on the microscopic appearance. So we discussed with you first the size,
it's
reduced, the consistency, firm. What about the surface?
The cortical surface has a fine, even granularity.
Yes, granularity. Can you explain why we see granularity of the surface? What do you think? What is the base of this granularity? Do you remember when we discussed with you the slide, histological slide, we saw that some glomeruli undergo sclerosis. They become smaller in size, and some glomeruli become hypertrophied. That's why. Yes? Do you understand me?
Hypertrophy of normal glomerular tuft.
Yes. Hypertrophy of normal gives us this like bulla and dystrophy and sclerosis gives us this narrowing of the cortex and medulla. Okay. Что человек? Okay. What material is deposited in arterioles, in glomeruli?
Hyaline.
Perfect.
Hyaline.
Yes, you're right. And the third question.
Is it that describe the histological changes in the kidney? and explain the mechanism of their development. Narrowing of the lumen of the arterial and small arteries caused by thickening and hyalinization of the walls, hyaline arteriosclerosis.
Exactly. Also, we see hyalinosis and sclerosis of some glomerula, atrophy of tubules, sclerosis of the interstitium, and hypertrophy of the survived glomerula. Они тебя слышат. Okay, can we proceed? We have very interesting questions. Last questions.
Yes.
Okay. What pathologic process can be found in the heart?
Tiger heart.
Tiger heart, fatty changes.
Exactly. I'm surprised. Yes, you're correct. You're right. Very good.
Can we see also a hypertrophic left ventricle?
Yes. Due to high blood pressure. We will discuss it later on adaptation. It would be concentric hypertrophy. High blood pressure triggers the heart muscles to grow, and cardiomyocytes become bigger, and they have more fibrils inside. This would be called hypertrophy. Okay. And we have the last question. This question, it's not very hard. You know the answers. You just have to think. I told you that
atrophy of the cerebral cortex. Atrophy of the cerebral cortex.
Well, I can't say that you are wrong, because in atherosclerosis, there would be atrophy of the cerebral cortex. But this is not I'm asking about. But you're correct. What else?
Maybe
hyalinosis.
Yes. Can you explain why?
Yeah, that's maybe because of hypoxia, there's going to be brain hematoma. And maybe because of that, there's going to be hyalinosis in the brain arteries.
No.
Because of hypoxia, there is hyalinosis in the brain arteries.
Okay, listen to me. You're right that there would be hyalinosis. Why hyalinosis? Because of high blood pressure, there would be damage of all arteries, not only in the brain, but you remember the spleen artery, and we had the hyalinosis also. So in person with systemic hypertension, hyalinosis would be profound in all organs, in all arterioles, in the skin, for example. And in the case of brain, we see hyalinosis of the brain arteries, small arteries, they're called arterioles. And this can be cause of hypoxia in the brain, hyalinosis of the brain arteries. Atherosclerosis of the brain arteries with formation of, for example, thrombotic masses can be a cause of ischemic infarct in the brain. Formation of aneurysm in atherosclerosis and rupture of aneurysm can cause hematoma of the brain. So here we focus on histological changes in the brain in hypertension. There would be hyalinosis of the brain arteries. Okay?
Yes.
Yes, thank you.
Yes, yes, I know. After coronavirus, go to a place and change it number by number machine. Change it.
Okay.
My university.
So I can show you the next slide with answers.
I'm a medical student.
Okay. Mm-hmm. So we will discuss with you the answers, the cases. We have time. If you have some questions, you can ask me.
Can you answer of case 7 once more, please, if it's possible?
Case 7?
Yes, ma'am.
Answers to the case 7.
Yes, ma'am.
Yeah, okay. Mm-hmm. Okay. So maybe somebody wants to tell me something or ask me about.
Yes, I have a question. Can we have your phone number or something to call you, or just email?
I think yes.
Just email?
I can give you my phone number.
Okay, all right. Can you write it into the chat or say it to me? I will write it down.
Okay, if I find the chat. Yes, I see the chat.
Okay, great.
Perfect. Perfect. Frankly speaking, it's my first experience. That's why it's so. I don't see.
Madam,
yes, do you see my?
we wrote the names of who is present today in the class.
Okay, thank you very much. Thank you. Now I need to save it somehow. Okay. Yes, I will save the chart, and this would be your presence for today.
Okay.
But what I'm thinking about, I think we can meet not only once a week in such a way. We can have, for example, 2 classes a week. And as we have such a distant education, not only I would be involved in these seminars, in the lectures, in the consultations. We will make somehow a schedule with these seminars or consultations with you. What I think is that the next meeting can be on Friday. What do you think about this?
Yes, but what time? Because we have already some classes there.
And tell me, please, do you have classes according to your schedule?
Some subjects, yes, but not all of them. All of them.
Okay. So we'll be in contact and we'll see. Okay.
Yes.
Because today I wanted to start from Monday, to try this application, and I know that somebody couldn't do it earlier, someone couldn't do it later, but at 6 o'clock everybody is free, I suppose.
Yes, at 6 we are free.
So anyway, if it would be at 6 o'clock, I think it's convenient. We don't have possibility to go to the street. That's why it's okay for us. Okay. Okay. So do you have questions to me? No. I hope you're
Would you please
feeling
add
well.
your phone number or email, I guess?
I've already sent you
chat.
my phone number, but I ask you just
can you write
message
in the chat phone number, your phone number or email in the chat? Can you write?
In the chat is already my website.
No, I can't see it.
Professor,
Okay, I
can see
will
it.
copy, just copy. Oops. Oops. Yes, finally, I took it. Moment. I lost my Zoom application. Oh, yes, here it is. So this is our new website. And there you have to find our department. No, on the previous site, you had to find the course and the subject. And there were the MCQs and material. The same is here. You have to find our department, anatomical pathology, named after Strukov. So anatomical pathology, we are the only one. And there are the materials according to topics. Just today I put there all materials, lecture material for the first semester and seminars and MCQs. About MCQs, as we need to study, but we can't meet face to face, I want you to write MCQs and to send me print screens of your marks. Maybe we'll do like this. Maybe it's hard if all the faculty would send to me, but you can send print screen to your teacher. Does everybody have contacts with their teachers? So anyway, if you have some problems contacting with teachers, you can write me. Okay.
Which teachers exactly?
So we are me, Tatiana Demura. Also, we have Sofia Demura. We have Ekaterina Rudenko. We have Anna Kukleva. We have Professor Evgenia Alexandrovna Kogan. We have Lyubov Severgina and Tatiana Nekrasova. I ask you to try to find MCQs, tests on the portal, on this new portal, if you see them or not.
Professor, I don't see any MCQs or any link related to pathoanatomy.
Mm-hmm.
I only see pathophysiology, but not pathoanatomy.
And do you have anatomic pathology?
Unfortunately, no, Professor. No, it's not there.
Okay, I will have to clarify this situation because I know the same thing happened with the Russian students today. Not everybody had possibility to join the portal, but you can enter the portal.
Actually, we can find the pathological anatomy named after academician Bukov. But if you, if I choose, for example, for today, what do we say? How do we say? The lesson of today.
Okay.
It doesn't open. It says that you cannot enroll in this course.
Okay. I have to look at this. So I hope that to our next meeting, I will find out how to manage this situation. Maybe this is just in some so I have to contact technical support. So you see the course, but you can't roll in.
Yes.
I can't even see the course.
And there's no MCQ.
Mm-hmm. Okay. Okay. So, okay. I'll try to solve this problem.
Teacher, for me, I cannot even see the course. Like I entered to Electronia образовательные ресурсы, and then I chose EOP, and then I didn't find it.
I'll try to make the instructions. So first of all, I will contact with support, technical support, and we'll try to make the instructions for you. Because it can be that it just something is not working properly.
Thank you very much, teacher.
Okay, thank you. Guys, hope you're feeling well. Take care, please.
You too.
Be careful, and I hope to see you in May. Face to face, and we communicate in Zoom. We'll see if it's convenient for us or not. So today, not everything was good, but finally we did it. So thank you very much for.
Thank you.
Thank you.
Thank you so much, ma'am.
Thank you.
Bye.
See you. So keep in
See you,
contact.
ma'am.
We'll discuss where we meet next time. Good.